Hello friends, today we are going to discuss acute stridor. Stridor itself is an urgency. It is an ominous sign. It denotes some partial obstruction of the upper airway. Stridor can be broadly approached as a acute stridor and chronic stridor, but chronic stridor you can wait, you can manage. But acute stridor is a real medical emergency, and that has to be that affected child should be treated very urgently. Coming to the respiratory noises, the three important respiratory noises are stridor, wheeze, and grunt. Stridor denotes partial obstruction of the extrathoracic airway, whereas wheeze denotes obstruction happening at the intrathoracic airway. Whereas grunt is a physiological CPAP. Actually, that happens in a newborn or infants. Actually, the affected child breathe through the closed glottis, and this causes increase of end expiratory pressure, thereby allowing more oxygen exchange. So it is a physiological CPAP. Other noises are all not very important. I think they are not a medical emergency, only you have to know that. Stertor means pooling of secretions that happen in neurologically impaired child. Snoring, everybody knows, happen in the sleep. Snuffles is the one that this sound happens in the newborn, particularly the young infants in the colds because of the crust in the nose. And chest rattle denotes secretions. So you should have some knowledge about the respiratory noises. Then what is the difference between the stridor and wheeze? Actually, you can have an imagination. You should have an imaginary line that going in the middle of the trachea. You all know our root of the neck, and in the root of the neck, if you make an imaginary line, horizontal line, it divides the trachea into upper half and lower half. The upper half, it is also called cervical trachea, whereas the lower half, it is called as intrathoracic trachea. So actually anything about the middle of the trachea, that is cervical trachea, larynx, supraglottic structures, all these things are all called as upper airway, and any compression or any narrowing or any partial obstruction occurs in the upper airway or extrathoracic airway results in a sound that is called stridor. Actually, this sound happens during inspiratory phase. It is because of the dynamics is such that actually the extrathoracic airway is subject to compress by atmospheric pressure. That is the reason why any obstruction in the extrathoracic compartment produces a sound that is called stridor, that is predominantly in inspiratory quality or inspiratory phase. Whereas below the middle of the trachea, that is the lower trachea and bronchi, bronchiole, in all these levels, if the obstruction occur, it produces a sound that is called wheeze. So intrathoracic obstruction produces a wheeze. It is a musical sound. Typically happens in expiratory phase because it is subjected to the intrathoracic pressure, unlike the stridor, which is subject to compressed by the atmospheric pressure. You should know all these things. I think if you know the fundamentals, you cannot afford to miss the bus. Then what is a stridor? So stridor is a loud, harsh, vibrating sound, growing in quality. That's sort of the sound. So actually this typically, once you heard that sound, you cannot afford to forget, and it is a loud, harsh, vibrating sound, predominantly in inspiratory. Actually, this is an inspiratory sound, and it is due to the obstruction of the extrathoracic airway. See, you can look at that. This is a, what is this? This is a glottis. This is a narrowest portion. In children, particularly before 9 or 10 years, the narrowest part is the glottis. Unlike the adult, which is the narrowest part, In adults, the narrow spot is the vocal cords, whereas in children, the narrowest spot is the glottis. Actually, if some pathology happens here that proves a sound that is not typically inspiratory, that may be biphasic. So, by hearing the biphasic stridor, you can localize the pathology, that is pathology is happening in the glottic or subglottic area. I think these knowledges are very important, and with this background knowledge, how to approach a stridor. Stridor can be approached as acute and chronic. And again, each division can be divided into infectious causes and non-infectious causes. Actually, this is a very useful way of approach. Actually, for a clinical or the management purpose or in day-to-day practice, this approach is very important. What are the conditions that produce acute stridor? So, acute stridor is caused by the right side viral croup, bacterial tracheitis, retropharyngeal abscess, laryngeal diphtheria, epiglottitis, lead and all these things. Actually, these are the infections. Mostly they are all viral infections except viral croup. All these infections are caused by the bacteria. So you all know that bacterial infection is always dramatic. They may compromise. Actually, if it is not treated or the child is not properly managed, that will go for respiratory compromise and respiratory arrest. Some of the acute non-infectious causes like foreign body, angioedema, edema, vocal cord paralysis, all these things you should be familiar. In this lecture, I am not going to discuss anything about the chronic. We are going to concentrate only in the acute causes. Acute stridor, clinical examination, if you make child, I already said most of them are viral infections, most of them except viral first croup, all are bacterial infections, though child will have a very high fever, severe respiratory distress, sometimes they have a swelling of the neck, stiff neck, torticollis, saturation may also drops. You have to monitor the child very closely, and some of the conditions are dramatic in onset that you should remember. So clinical examination is very important, though I am not fully going individual cases. Now I am giving a broad outline how to approach these cases. First, acute laryngotracheobronchitis, it is commonly called as croup. If somebody tell croup, it denotes viral croup. Okay. So the best terminology is laryngotracheobronchitis. Even though this infection starts and expands from the larynx to bronchus, most of the infection happening only in the larynx, particularly in the glottis area. These children typically start with a viral prodrome. Actually, in autumn or early spring, suddenly child's voice may change, presenting with a barking cough, still like barking cough. Stridor, to start with very mild, then it will slowly increase, audible also, something like sound you cannot miss it. And the symptoms appear to be increased in the night. Actually, in the night hours, the child's symptoms will be very high, and slowly they develop all signs of dyspnea, including suprasternal retractions and all. So this croup, laryngotracheal bronchitis, is caused by the para-influenza virus. I think majority, 50 to 60% of the cases is due to para-influenza type B. There are other viruses like RSV, rhino, influenza, all these conditions also capable of producing croup. Usually, X-ray is not necessary, but most of the time they come with the X-rays. If you look at the X-ray, you can see the subglottic narrowing. Can you see here? It is something like a pencil tip. That is the reason why it is called as a pencil tip sign. Sometimes it is also called such steeple sign. Actually, this very not normally it won't be like that. Here, because of the narrowing that happened in the glottis, you can get a pencil tip sign and all. Croup we can broadly classify as a mild one, moderate, and severe. Actually, majority of them they may have a mild problem. They started with a viral prodrome, barking cough. They may not be having a distress. Saturation may be normal. These children can be treated or they given a single dose of steroid and send they become all right. But on the other hand, some of the children, a small percentage will progress to moderate group. Actually, the child get agitated. Stridor become more and more. Heart rate increases, respiratory increases, retractions, suprasternal retractions also very typical. And if you look at the saturation, it may start drop. So these children should be, in addition to steroid, they definitely need oxygen. Actually, these children should be admitted and you have to manage. Severe Croup is the one that needs ICU admission. Here, the child will be having stridor even at rest. And because of the hypoxia, child looks anxious. They may not like to take anything. And the vital signs like heart rate and respiratory rate increase. And they may even go for cyanosis and the saturation drops below 92 and all. Actually, it's a medical emergency. And we have to, in addition to steroids, we have to put them a child on adrenaline, oxygen, and these children should be monitored very, very closely. Otherwise, they go for a respiratory compromise and respiratory failure and all. The key drugs in the management of viral group is a steroid. Steroids are available in three forms: dexamethasone, prednisolone, nebulized budesonide. I think whatever available you can treat, because nebulized forms may not be available in a OP settings and all. So even a single dose of dexamethasone in a mild group will be very, very, very useful, because whatever forms of treatment, either all the steroids act unlike the other hormones and all. Steroid acts in a different way. Actually, they doesn't stimulate any surface membrane receptors. Actually, they enter into the cell, they reach the nuclei, they changes the ribosomal prescription and result in some molecules like lipomodulin, macrocortin, and these are the proteins that going to execute the actions of. Actually, steroid is the one that supposed to reduce all the inflammatory signs that are happening in the body. So whatever steroids available you have to give. Ideally, in OP setting you can use dexamethasone. This is because unlike the other steroid, dexamethasone will act for 2 to 3 days. Even a single dose may be very useful. So we have to necessarily use steroid. And when the child's condition becomes severe or stridor becomes more and more, you have to use L-epinephrine. That is also called adrenaline. Those days we are all using racemic epinephrine. After that, study shows that both racemic and levoepinephrines are equally effective. So the normal epinephrine can be used in the dose of 0.5 ml, and it will go for only there in the body for 3 to 4 hours. Then child get recurrent symptoms. So the dose get repeated. I think this L-epinephrine or epinephrine is very useful in Croup because of the alpha action. Because of the alpha action, it reduces the mucosal edema, and it also causes vasoconstriction. And by virtue of beta action, it causes bronchodilation. That's the reason why epinephrine plays a very major role in the management of Croup, particularly in severe Croup. Actually, the same drug is a very useful one, especially in the management of anaphylaxis, angioedema, acute asthma, all these things. Probably, I think that is the reason why still epinephrine plays a major role in the management of anaphylaxis. These children should be supported with oxygen. Oxygen can be given any forms. There are many ways of delivery systems are available. I personally advise even a nasal cannula. Now, if you give oxygen through the nasal cannula, particularly if you give 1 to 4 liters, that increase the oxygen it will maintain the oxygen between 24 to 40%. So I think nasal cannula appears to be very simple, safe, easily tolerated, and it delivers low concentrations also. But if the child is going to be a struggling child, you have to make them quiet. Why I am telling is, when the child becomes struggle or cry, that flow becomes turbulent. Actually, flow itself is a turbulent, but become more turbulent. So normally, what they say, whenever there is a airway resistance, is the fourth power of the radius, giving a laminar flow. But it's become a turbulent, then it becomes the fifth power of the radius. That is the reason why when the child is, you should give maximum comfort to the child not to cry. The best way, whatever the child assumes, and it is better to keep on the child's mother's lap and all. I think very senior practitioners always insist all these things. And if you make the child on the mother's lap, the child may be little comfort, the stridor may come down, and his oxygenation status also may improve. Now we'll go to the other important cause, bacterial tracheitis. In those days, the second position was given to supraglottitis or epiglottitis. But unfortunately, the disease has come down. Anyway, I am going to talk about that little later. Nowadays, bacterial tracheitis is one of the condition that may produce a more or less, it is similar to viral croup. And only thing is, the child may appear to be toxic, and it will be an older child, 3 to 8 years and all, and the stridor may be developing, child may appear show high fever and toxic, and it may also produce a lot of mucus, mucopurulent secretions may be coughed out, and it also happen to be in winter. The commonest organism implicated with the bacterial tracheitis is Staphylococcus. Actually, Staphylococcus, by virtue of infection, it will produce a pseudomembrane in the trachea. That is the reason why in this condition, bronchoscopy plays a very important role. Actually, in bacterial tracheitis, bronchoscopy is both diagnostic and therapeutic. Actually, if you put a normal saline, you can culture, and you can also give a nice toilet, pulmonary toilet, thereby you can remove this pseudomembrane that will make the child to breathe. And the child should be immediately put on anti-staph antibiotics, particularly ceftriaxone, or it all depend upon the toxicity. You can go Vanco, Clinda, and other groups of drugs. Actually, after the advent of or extensive coverage of HIV vaccination, epiglottitis causing a bacterial croup has come down. Now the bacterial tracheitis become increasing. The prevalence of these conditions become increasing. So I said epiglottitis, I think 1980s and all, epiglottitis is the one that's a real problem. Actually, we all introduced HIV vaccine in 1980. After that, this condition epiglottitis starts coming down. Those days, when child develop epiglottitis, it is a severe inflammation of the epiglottis, and the child will have a severe throat, toxemia might be there, and typically the children may not have a cough. Why they are not having cough? Any answer? Actually, the reason is, even though all the upper airway, all these and cough receptors, it is the epiglottis is the one that devoid of cough receptors. That is the reason why in this condition cough may not be there. And this condition is life-threatening, and because of the severe respiratory distress, child may assume tripod position. See, it supports body. So the classical triad is dysphagia, drooling, and distress. Any child presenting, but unfortunately this situation is not happening because of the extensive coverage of HIV vaccine. Actually, if we go into the history, it happened in adults also. The first president of USA, George Washington, also, I think, he suffered with epiglottitis. That is this condition. Look at the picture. It is a nice drawn. What I want to show is this epiglottitis. Actually, this gets inflamed. Okay, and once it's inflamed, it becomes like a thumb. It is called thumb sign or vallecula sign. The whole vallecula may be disappear. And if epiglottis is subjected, we should not, unless the child, unless there is a for proper person to secure airway, we should not do any other procedure. You should not do laryngoscopy. You should not open the mouth and all, because they suddenly go for a spasm. So if you strongly suspect epiglottitis, actually the child should be taken to the theater, and in the presence of anesthesia, he should be in a position to secure the airway. Then only you can. Actually, this is only a picture that I get it from the net to show you how it is a severe inflammation is happening in the epiglottis area. So unnecessary oral explanation to be avoided, and oral examination should be done in a proper setup, either a ICU setup or in the anesthesia, and or a critical specialist should be with us to secure the airway. Now we will go on to the another important condition, diphtheria. I think diphtheria, with all our efforts of vaccination, diphtheria is still there with us, especially in developed countries. This is a condition caused by a Corynebacterium diphtheria, and it is a potentially lethal URTI. Still, it is reported in developing countries. And what diphtheria is means, it produces a exotoxin. The exotoxin, particularly A, is the one that enter in the cell and inhibits the protein synthesis, causing the cell death. That is the reason why the dead cells or debris appear as a grayish membrane in the throat. Actually, this toxin also enter into the bloodstream and produce later complications like myocarditis, palatal palsy, GBS, all these things. That is the reason why people say that when you strongly suspect diphtheria, or if you happen to see a grayish membrane on the throat, particularly on the anterior passes, anterior pillars of the tonsil, or in the posterior pharynx and all, you have to immediately use diphtheria antitoxin. Actually, it should be used depending upon the site, either a single site or extensive area. At least 40,000 units should be given. And to kill the organism, we have to use penicillin. And can you see, this is a cocobacillus. Actually, Corynebacterium diphtheria is a cocobacillus, club-shaped one. And here Albert stain is used to demonstrate the metachromic granules and all, which can easily be done. Coming to the fifth condition, retropharyngeal abscess. Retropharyngeal abscess, as the name suggests, it is happening in the posterior pharynx. It is nothing but the collection of pus in the retropharyngeal area. Can you see here? This area is a retropharynx. The pus get collected here. How it get collected? It is because of the infections from the tonsil or teeth, and it will invariably be a polymicrobial infection. And normally, if you take this X-ray, and if you measure that retropharyngeal soft tissue, if anything more than 7 millimeter at C2 level, then it confirms retropharyngeal abscess, or 14 millimeter and above in C6 level, then it confirms. Many people say compare the vertebra and the soft tissue. If it is more than half the size of vertebral diameter, that confirms retropharyngeal abscess. These are the children's, like other children, they also produces a noisy breathing, dysphagia, swelling of the source, torticollis. All these things will be typically there, and it is a surgical emergency, and the child should be immediately admitted, and ENT surgeon should be called to do incision and drainage with a proper anesthetic support and all. Ludwig's angina, this thing I want to definitely talk in this occasion, because at one time I happened to be very, very difficult to manage this condition. One child, it is still, I remember, it is a twin, and the child developed a huge swelling of the neck. Ludwig's angina itself is a cellulitis. The cellulitis is the one that happening in all the three components, sublingual, submental, submandibular. So it is really a life-threatening situation. Diffuse, it causes a diffuse neck swelling. Child may have a very high fever, toxemia might be there, trismus may be there, and it is a potentially it is a potential, it causes airway obstruction and all. So that is the reason why it should be made, the diagnosis should be very made early. And since it is caused by mixed or organism, particularly the anaerobic organism, streptococci and staphylococci and all, we have to use high dose penicillin in addition to incision and draining. Actually, why I did, the knowledge is the power. Once you happen to see such a child, you never forget in your lifetime. So that is the reason why when such a child get admitted in any ward, you have to rush and go and see what is happening, how they are treating and all. So I covered in the acute stridor many causes, infectious causes. Now left with one or two non-infectious causes. I think some of the non-infectious causes also produce a acute stridor, of which the most important thing is sudden onset, without fever, focal signs, think of foreign body. Clinical examination is very, very important. I already showed my slides, and by proper history, you can find out some probable diagnosis. So, in the clinical history, anything is a sudden onset. If the mother says, yes, my child swallowed something, it should be given importance. And such a history can be obtained only in 50% of the cases. So if the mother says, then it has to be taken in a very severe way, and the child should be subjected for proper investigation. Particularly, the child should be subjected for rigid bronchoscopy. And if you have a suspicion, and if nothing, you are not, if the history is not very highly suggestive, then you can have a flexible bronchoscopy to see. Once you see, then it has to be immediately removed with a rigid bronchoscopy and all. Foreign body in the airway, very common, is more commonly happened in 3 years, but it can possible from 6 to 5 years. I already said positive history from the parents should be never ignored, and such a child typically present triad of symptoms like a coughing, choking and wheezing. It all depend upon the placement of where the foreign body gets locked. And probably I like to just to see that of all the foreign bodies, peanuts is a very, very common one. Okay. And can you see this child is presenting with a noisy breathing, difficulty to speak, cough, labored breathing and all. X-ray shows bilateral ventilation. And this is not very typical of foreign body, but still when the foreign body is going to be there at trachea, it acts like a central foreign body. It allows the air go down and simply cause bilateral hyperventilation. So these are the things. Sometimes central foreign bodies are very, very dangerous. So if you suspect central foreign body, immediately the child should be subjected for rigid bronchoscopy removal and all. Because if you don't postpone, once you make a diagnosis of foreign body, you should make all the attempts to remove the foreign body in the same day itself. And that is very important. Coming to the angioedema, it is nothing but a type of allergic reaction. Basically, it is Ig mediated, and these allergic Ig mediated are always the background of histaminergic reaction. So angioedema is most commonly occurs in allergic individuals. Child may be allergic to many things, starting from either their food or outside pollen, or sometimes they may be allergic to many things and sudden develop angioedema, particularly in the lips, face, neck, and even the larynx may involved. So sometimes very easily, if you look at the urticaria or itchy rash over the other parts of the body, you can make a diagnosis and all. Remember, most of the angioedemas because of anaphylactic type of reaction caused by IgE. But there are other situations also happening that you have to remember. Sometimes it may be related to drug or non-allergic causes also produces this one and all. But whatever may be the thing, the first one you have to treat the child with adrenaline, fluids and H1 antagonist, corticosteroid should be used. Of all these things, aero management is very, very important. And why I put this slide here, because some of the angioedema, because of the involvement of the larynx, They typically present with stridor and all. Hereditary angioedema is the one different one, but actually it is a recurrent phenomena. Recurrence will happen, or recurrent urticaria may happen. This is because of the C1 esterase inhibitor deficiency. Actually, if you see the complement mechanism and all, it is the C1 esterase is the one that plays a very important role, and it acts like a control over the alternate pathway. And that is the reason why, and sometimes some of the children have genetic mutations with the C1 esterase inhibitor deficiency, and they typically go for angioedema recurrently. This is because of the release of anaphylactoxins that are happening in the body. Actually, this angioedema, hereditary angioedema, is something different from the normal angioedema, because the normal angioedema is histamine related. Here, the bradykinin and kallikreins are involved, so it is not response to your antihistamine or even epinephrine. So these children should be benefited with the C1 inhibitor and infusion. I think this is only to complete the our lecture, and there are a lot of advances are happening in this field, and many people use icatibant, that is these medicines, kallikrein inhibitors are also available. Unfortunately, some children are suffer from this hereditary angioedema. We have to be knowledgeable about that. But all these things, most important, I want to say that primary focus is on the airway management. I think we are nearing end. I talked about upper airway obstruction, acute causes, and acute non-infectious causes. This is the best way to approach and all. To summarize, in the management of acute stridor, you have to know the age, history, clinical examination is very important. The commonest cause of acute stridor is a viral croup. Then we should knowledgeable about how to treat bacterial tracheitis and retropharyngeal abscess. Anything sudden onset is a foreign body. And if there is a neck swelling, think of diphtheria. And if there is a lip swelling and all, think of angioedema. Thank you very much.